What's up, Ninja Nerds? In this video today, we're going to be talking about ECG interpretation. Every clinician should have a very good systematic approach to how to read an ECG. Let's get into it. One of the approaches that I think is pretty good from a lot of the textbooks, and I think also maybe has some degree of clinical practice for myself, is I like to first just determine what the rate is. So I look at the ECG and I determine the rate. The reason why that's important is it tells me if the patient's tachycardic or bradycardic right away, or if they're just having a normal heart rate. The second step is to determine what the rhythm is. It narrow regular, narrow irregular, wide irregular. It helps me to determine if they are tachycardic, what type of arrhythmia are they having, or if they are bradycardic, it also may give me an idea of what kind of bradyarrhythmia they're in. Step 3 is I'd like to look at the axis to determine if there's any deviation. So left axis, right axis, extreme right axis deviation. The fourth thing is I like to evaluate the intervals. I really like to look at the PR interval first because it helps me significantly in determining the different types of bradyarrhythmias, especially AV blocks. I also find it may give a little bit of benefit to finding Wolff-Parkinson's-White syndrome. And I also like to look at the QT interval because the QT interval can help me to determine the patient's risk of torsades de pointes. I then like to assess the P wave to see if there's any evidence of left atrial or right atrial enlargement. And then I like to look at the QRS complex to see if there's any evidence of bundle branch blocks, like left bundle branch block, right bundle branch block, or ventricular hypertrophy, right or left. And then last, I like to assess the ST segment and the T wave to see if there's any evidence of myocardial ischemia or infarction. All right, my friends, now we're going to move into the first step here, which is we have to determine the patient's heart rate. This is going to be the necessary thing right off the get-go. So how do we do this? Let's say that you see this ECG and it kind of seems stressful. It's actually not that bad. What I really want to do is I kind of want to zoom in on this rhythm strip and show you guys how to calculate the heart rate. So when we do that, there's two different ways. I prefer the R-wave method. I find this to be very effective. And basically what you do is you count the number of R waves that are present in the rhythm strip. In this particular scenario, I count about 11. And then what you're going to do is you're going to multiply those number of R waves by 6. So it's 11 times 6, which is about 66 beats per minute. That right there will give me the rate that the patient's heart rate is. Another way that you could do this is you could actually zoom in kind of on this particular area here and count the number of boxes that are present between. So for example, if we really looked at the nitty gritty here, I could actually average this out truly, and I could say it's about 1, 2, 3, 4 boxes. There may be a little bit more here that it's extending outwards to, but what you do is you take 300, and the reason why it's 300 is one box is indicative of like 300 beats per minute. So what I do is I take 300 and I divide it by the number of boxes between one R wave and the other R wave. It's about 4 boxes, but it's just a little bit more. To be very specific, we're going to say it's about 4.5 boxes, which comes out to about 67 beats per minute. So that's the two ways that you could go about determining the heart rate. When you look at the ECG, look at the rhythm strip, either count the number of R waves, multiply by 6, or take the number of boxes between an R wave and an R wave and take that number of boxes and divide it from 300, and that should give you the heart rate. Once you've done that, it's then pretty simple. If the heart rate's greater than 100 beats per minute, it's tachycardia. If it's 60 to 100 beats per minute, it's a normal heart rate. And if it's less than 60 beats per minute, it's therefore bradycardia. All right, let's now move into the next portion here. All right, after we've determined the patient's heart rate, we then want to determine, okay, let's say that the heart rate's too fast. It's greater than 100 beats per minute. In that scenario, what I want to determine is, okay, they're tachycardic. What kind of tachycardic rhythm are they exhibiting? So I like to then assess what's the actual QRS complex. Is it narrow? Meaning, is it less than 120 milliseconds? 3 little boxes. And is the R to R interval regular? What does that mean? That means if I measure the distance from an R wave to an R wave, it's the same all the way down the rhythm strip. There's a bunch of different types of narrow regular tachycardias that I have to evaluate. One is sinus tachycardia. The way that I evaluate this is that, again, heart rate's greater than 100. It's narrow. QRS complexes, as you can see here, and the R to R intervals are consistent. What makes it different from the other three is that the P waves will be upright in lead 2, inverted in AVR, and every P wave will be followed by a QRS complex. For 2-to-1 atrial flutter, there won't be any visible P waves. Instead, in leads 2, 3, AVF, they'll have these flutter waves, which are very consistent. Also, the heart rate tends to be very consistent at 150, and that's very, very common for atrial flutter. But again, you'll notice a narrow QRS, and you'll notice that the R to R interval is the same. And the last one is paroxysmal supraventricular tachycardia. This could be AV-RT, like Wolff-Parkinson's-White, or AV-NRT, AV nodal reentrant tachycardia. And what you're looking for is really no P waves, and if sometimes you may be able to pick up like a retrograde P wave. But the big difference here is that there will not be any visible P wave, so that rules out sinus tachycardia, and no flutter waves, and this one can go pretty fast. Oftentimes it can get up to 170s, 180s. You can get pretty fast with these guys. And so that's the big difference. Oftentimes we also use vagal maneuvers and adenosine to really help to not only diagnose this, but also treat this type of disease. What if I said I have a narrow irregular tachycardia? So heart rate greater than 100 beats per minute. The QRS complex is narrow, less than 120 milliseconds, 3 little boxes, and the R-to-R interval is not the same every single time down the rhythm strip. I have 3 differentials. Atrial fibrillation would be one. I got to look for these fibrillatory waves. No obvious P waves are present. That's a problem. All right, so if there's irregular and fibrillatory waves are present, especially in lead 1, think about atrial fibrillation. Atrial flutter with a variable block is also interesting because in this one, you'll see that it's not constantly a 2-to-1, or it may be a 2-to-1, a 3-to-1, and it's bouncing back and forth where you have like 2 flutter waves, 3 flutter waves, and then a QRS complex. So it's not the same. So for example, if I looked at this R to R, this R to R, and this one is completely different than this one. This is, again, no fibrillatory waves. I can definitely see that there's some sawtooth waves here, but they're not consistent. It's not always a 2-to-1. It could be a 2-to-1 with a 3-to-1, and that's where you get the variability there and the irregularness of the R-to-R interval. The next one here is multifocal atrial tachycardia. Heart rate greater than 100 beats per minute, but here's the key difference. I will see P waves, but they'll all look different. If I have 3+ morphologically different P waves with a tachycardia and an irregular rhythm, and it's a narrow QRS complex, it's likely multifocal atrial tachycardia. Again, this is very common in patients with COPD. I go to the next one. I have a wide QRS complex. In this case, it's greater than 120 milliseconds, or 3 little boxes. All right, that's common. The R to R interval, if I calculate every R to R interval, it's always the same. When you see this, you think of ventricular tachycardia until proven otherwise, especially if all of this is the same. This is monomorphic. If I see wide, so again, greater than 120 milliseconds, or 3 little boxes the QRS complex is, and I see that the R to R interval is irregular, so it's not the same every single time, then I think about polymorphic ventricular tachycardia with a prolonged QT interval. So you see how this patient, they start having a prolonged QT, and then bang, they go into torsades de pointes. You can see how not every single one of these QRS complexes look exactly the same morphology. They're differing here. It kind of gets a little bit bigger, and then towards the center it kind of narrows down and then gets bigger again. And that's actually one of the classic looks, is it gives that kind of like ribbon look. This is very consistent of polymorphic ventricular tachycardia with a prolonged QT, also known as torsades de pointes. And the last one is the most terrifying one. This is usually ventricular fibrillation. Again, you can see how all the QRS complexes are not the same morphology, and they're not always exactly the same type of morphology, the same distance. So therefore, again, this is wide, and it's not the same R to R interval. Therefore, it is irregular. This is ventricular fibrillation. You see this, you get kind of scared, right? But that's important to be able to identify. So tachycardia, you want to know, is it narrow, wide, regular, irregular, and that'll generate your differentials. Now, with that being said, let's go to a patient who has a bradycardic rhythm. So their heart rate's less than 60 beats per minute. Then I got to start thinking, okay, could they have sinus bradycardia, or could they have an AV block? All right. Well, the first thing I want to do is look at the PR interval. If the PR interval is normal, they don't drop any QRS complexes, and every P is followed by a QRS, and it's, again, well, that's sinus bradycardia. If my PR interval is prolonged, every P wave is followed by a QRS complex, but I don't drop any QRSs. You know how to sound every P wave, QRS, P wave, QRS, P wave, QRS. Nothing changes. There's no droppage of the QRS, but the PR interval is prolonged in comparison to this one. In that particular scenario, if it's greater than 200 milliseconds, the PR interval, this patient has a first-degree AV block. Go to the next thing. The PR interval seems to be getting longer every single time. So it gets longer, longer, longer. And then here's the P wave, but then look what happens here. I don't have a QRS complex. I drop my QRS complex. So here I had a prolonged, but this one is prolonged and it's getting progressively longer, and then I drop a QRS. These are not the same. This is a second-degree AV block, Movitz 1. It's longer, longer drop. You have a winky bach. What else? If I have a PR interval that is prolonged, but it's constant, it's not changing, it's not like 160, or it's not, let's say 200, 220, 240, 260, it's not getting progressively longer. It's constant. And then what you notice is P, QRS, P, QRS, P, no QRS. I drop a QRS with a constant PR interval. This right here, my friends, is a second-degree Movitz 2. And the last one is if there's literally no relationship, there's just a ton of P waves, and then there's no QRSs that are constantly correlating with that. If you see a ton of P waves with no correlating QRS, and on top of that, the P waves are beating at their own rate, that's super suggestive of, again, a AV dissociation. So if the atria are beating at their own rate, the ventricles are beating at their own rate, and it's even wide complex, that suggests an infranodal AV block. This is super consistent with AV dissociation, which is very indicative of a third-degree AV block. So again, look at the rate, determine if they're bradycardic, tachycardic, then take that to the next step. Is it a narrow regular tachycardia, narrow irregular, wide irregular? Then it's bradycardic. Do they have sinus brady? What's their PR interval? Is it prolonged? Is it a first degree? Is it prolonged and dropped? Is it a second degree Movitz 1? Is it constant and then dropped? Second degree Movitz 2? Is there no relationship between the P waves and the QRS complexes? It's a third degree. I just determined my rhythms. Isn't that cool? The next thing is we said axis. So I looked at my rhythm, right? I looked at my rate, I looked at my rhythm. Now I'm gonna look at the axis. Okay, cool. How do I look at axis? All right, well, the first thing I gotta do here is I'm gonna look at lead 1. And what I wanna look at is I wanna look at the QRS complexes. I wanna see with the deflection, where is the most positive deflection? Is it upwards or is it downwards? In this one, it's upwards. So what I want you to do is I want you to take your left hand and lift up your thumb. All right, so that's gonna be thumbs up on that side. All right, that's the first thing I do. Second thing I do is I have to look at AVF. What's the QRS complex looking like? Is it upwards deflection or is it a downwards deflection? Now, in this case, it's upwards. Get that thumb up. When both thumbs are up, it's normal, baby. That's a normal axis. There's no true underlying pathology here. Now, in left axis deviation, it's different. Look at lead 1. What's the QRS? It's predominantly positive. All right, cool. Thumbs up with the left hand. Then look at AVF. Ooh, the QRS complex, this is predominantly negative. So the right thumb is going to go downwards. So if I have that, you would think, okay, this is left axis deviation, because the thumb that's always pointing up is usually indicative of which axis is deviated. But you got to be careful. So in this particular scenario, what I would do is when I see upright and negative, just be very careful because this still could be a normal axis. Look at lead 2. And if you look at lead 2 and you see that it's predominantly negative here, that definitely confirms that it's actually going to be what? Left axis deviation. But if you look here and it was predominantly positive, then it would be a normal axis. But again, I look here, up, I look here, down, I look here, and it's predominantly appears negative. And or you could even say equiphasic. That is indicative of left axis deviation. Question is what causes left axis deviation? It's usually anything that alters the depolarization of like the left ventricle, all right? Usually via like the bundle system. So I think a good couple examples here would be a left bundle branch block. That's a very common one. Left ventricular hypertrophy, which can actually cause a lot of strain and stretching of the left bundle branch. And on top of that, a left anterior fascicular block can also cause a left axis deviation. All right, what about right axis deviation? Okay, look at lead 1. It's predominantly negative, thumb down. Go to lead AVF, predominantly positive. So I got this one down, this one up. That's right axis deviation, baby. The thumb that's pointing up tells me what the actual kind of deviation it is. So then I got to think about it. There's something wrong with the right ventricle. It's either a right bundle branch block, right ventricular hypertrophy, or a left posterior fascicular block. So left axis is left bundle, left ventricular hypertrophy, left anterior fascicular block. Right axis, right bundle, right ventricular hypertrophy, left posterior fascicular block. The last one is extreme right axis deviation. I think if you saw this, you wouldn't be worried about axis. You'd be worried about, does this patient have a pulse or not? But the concept remains the same if you're evaluating axis. What's the lead one show? It shows a downward deflection predominantly. So the thumb's down with the left. If you look at AVF, what does it show? Is there's a predominant downward deflection. And in this case here, if both thumbs are pointing down, that's extreme right axis deviation. The most common etiology of this is usually monomorphic VTAC. All right. So we've then said, okay, what's the rate? Is it a tachycardic rhythm? A bradycardic rhythm? Which type is it? Then we also evaluated the axis. Is it normal? Is it left axis? If it is, could it be due to left bundle branch block, left ventricular hypertrophy, left anterior fascicular block? Is it a right axis deviation? In that particular scenario, again, could it be right bundle branch block, right ventricular hypertrophy, left posterior fascicular block? Or is it extreme right axis, which you can see in VTAC? You can also see in variants of Wolff-Parkinson's-White syndrome. We go to the next thing, approach to intervals. There's two intervals I think are very important to remember. One is the PR interval and the other one is the QT interval. The question I want you to know is the PR interval prolonged or shortened? Now, if it's prolonged, that tells me about AV blocks, right? For example, if it's greater than 200 milliseconds, right, that's prolonged. In this case, it could be a first degree AV block if I don't drop a QRS. It could be a second degree Mobitz 1 if I drop a QRS as it gets longer and longer and longer. If it's a constantly prolonged PR interval and I drop a QRS, that could be indicative of the Mobitz 2. And in third degree AV blocks, you're going to see these super abnormal, multiple frequent P waves with no true relationship between the actual patient having a atrial and ventricular association. All right, that's pretty straightforward, right? For short, this one's not as high yield, but it is important to think about this because one disease that actually may come up in your exams is Wolff-Parkinson's-White syndrome. This one can have a very short PR interval, less than 160 milliseconds. The concept behind this is look for two other findings. So there's a triad. There is a delta wave, which is this kind of brief upstroke here. There is the very, very kind of like short PR interval here. And then there's that kind of wide QRS complex. That's usually indicative of Wolff-Parkinson's-White syndrome via the bundle of Kent. Then I like to look at the QT interval. So I like to measure between this part here, coming all the way to the end of the T wave and knowing what that QT interval is. Now, it is important to remember that this can vary based upon male, female, and there's a lot of different numbers. I like to remember basically if the QT interval is greater than half of the R to R interval, so the distance between this R wave and this R wave, if that QT is greater than half, that is prolonged. Sometimes I like to just remember also if it's greater than 500 milliseconds. In that particular situation, these patients are super high risk for something called torsades de pointes. The causes you have to be thinking about here include drugs such as antiarrhythmics like amiodarone, abutolide, antibiotics such as macrolides, antipsychotics like haloperidol, quetiapine, antidepressants such as SSRIs and TCAs, antiemetics like ondansetron or compazine, and here's the big ones, baby: hypokalemia, hypomagnesemia, and hypocalcemia. These can all prolong the QT, increasing the risk of torsades de pointes. That's important to remember. The short QT interval I wouldn't worry as much about too significantly, but do remember that if the QT interval is very, very short, like less than maybe like 460 potentially, it does create the slight increased risk for tachycardia, so you may see this with hypercalcemia and hyperkalemia. Not as high yield though. All right, that's intervals. We now go to the P waves to determine if there's atrial enlargement. So when I look at the P waves, I want to know, does the patient have left atrial enlargement or right atrial enlargement? So I'd like to look at lead 2 first. When I look at lead 2 and I really zoom in here, I kind of see this configuration when I zoom in. You see how the P wave appears to have like a split? We call that a bifid P wave. When you see bifid P waves and lead 2, that makes me think about left atrial enlargement. So then what I got to do is I got to confirm that. And I go to lead V1. And when I look at V1, I want to see a biphasic P wave. And if I see the biphasic P wave, but I see here that the terminal component is bigger than this little initial component, if I fill that in there, that's definitely indicative of left atrial enlargement. And that's super important because there's different reasons why patients could have left atrial enlargement. Their left atrial pressures could be high because their left ventricular pressures are high in scenarios of left heart failure. It could be due to a cardiomyopathy that creates elevated left ventricular pressures, or it could be due to mitral valve diseases that cause left atrial pressures to be high in the scenario like mitral valve stenosis example is that what would it be. All right, what if I saw this one where I look here and I say, oh shoot, that P wave be big, baby. That thing is greater than or equal to 2.5 millimeters. In this particular scenario, that's a very high peaked type of P wave. If I see that, I'm thinking right atrial enlargement, but I got to confirm. So I'm going to go to V1. And when I go to V1, I should see a biphasic P wave. But in the comparison between left and right atrial enlargement, the initial component should be larger than the terminal component. And if I see both of these, it's highly indicative of right atrial enlargement. And I want to think about what? Usually pulmonary hypertension can create elevated right ventricular pressures and as a result cause right atrial enlargement, or tricuspid disease such as tricuspid stenosis. All right, that's not too bad, right? All right, we get to the QRS complex now. I want to know, does the patient have bundle branch blocks or ventricular hypertrophy? All right, so let's say I want to assess these patients for bundle branch blocks potentially. Well, how do I do that? Well, I like to look at V1 and V2 first, all right? And what I want to see is I want to see something called an RS wave. I just want you to really look here for a very deep S wave in V1 and V2. So you see how there's like this little R wave? And then boom, you see this huge, huge S wave here, right? When I see a very large S wave in the V1 and V2 precordial leads, and then I see this very large notched like R wave in V5 or V6, this is super, super suggestive of a type of bundle branch block. And usually this is indicative of a left bundle branch block. Now, left bundle branch blocks, what's important to remember with this one is it's usually due to something that's like stretching or thickening the left ventricle. So this could be due to left heart failure, right? Especially systolic heart failure. It could be due to myocardial infarction, which kind of knocks off the left bundle branch block, or the left bundle branch. You could actually infarct it and cause fibrosis of that bundle branch. Or left ventricular hypertrophy, where you thicken that actual myocardium and compress on the left bundle branch. This is very common. When I see this next concept, I see this R, S, R prime wave in V1, V2, or I see the M, that automatically makes me think about a right bundle branch block. What would even confirm it more is if I looked over at V5 and V6 and saw something interesting here. If I see like this wide, slurred like S wave, so you see how it goes Q, R, and then look at the S wave. You see the distance here? Right here, that wide slurred type of S wave, that is so suggestive there of a what? A right bundle branch block. So the combination of these two, right bundle branch block, baby. What would cause that? Something that's going to stretch out the right ventricle or thicken the right ventricle or infarct parts of the right bundle branch block. Pulmonary hypertension will cause right ventricular hypertrophy, maybe even right ventricular dilation. And myocardial infarction, like a right ventricular MI, could also kind of cause fibrosis of the right bundle branch. All right. So that's blocks. What about hypertrophy now? Well, with hypertrophy, I want to look again at V1 and V2. And I want to see what these S waves do. So if these S waves are like crazy deep, I'm talking insanely deep here, right? And then I go ahead and I look over at V5 and V6 and I see that these R waves are like through the roof. That's super suggestive of left ventricular hypertrophy. Now, There is different criteria that you can do, so you can add up the amount of boxes of the S wave and then add up the amount of boxes of the R wave, and if it's greater than 35 millimeters, it's usually suggestive of left ventricular hypertrophy. And that's one thing that we could do. But if I see a super deep S wave and a very large R wave, I definitely want to be thinking about left ventricular hypertrophy, right? This is super common in patients who have like aortic stenosis or hypertension. Now with right ventricular hypertrophy, I want to see very tall R waves in V1 and V2, very tall R waves. And then I want to look over in V6, and what I want to see is I want to see the S waves being much bigger than usual. They're definitely not usually this big. And so when I see this, that definitely gives me the idea of what's called right ventricular hypertrophy. So then I would be thinking again about pulmonary hypertension is a very, very common cause here. All right. All right. We move on to the next component here, and this is the behemoth. This is where it really counts. You can't miss some of this stuff here. So I want to talk about how do we approach the ST segment and the T waves, especially if a patient comes in with angina, so chest pain. When you assess the ST segments, you want to know, does it look like it's depressed? So in other words, when I look at the J point, where does it look in comparison to this kind of isoelectric line? If that is depressed greater than 0.5 millimeters in V2 and V3, or at least greater than 1 millimeter in all other leads, and it has to usually be contiguous, that's consistent with ST depression. The other thing I like to know about ST depression is morphology. I want to know, does it look like it's horizontal? Because that's concerning for ischemia. Does it look like it's downsloping? That's also concerning for ischemia. The one that's maybe not as concerning could be upsloping, but if I see horizontal and downsloping ST depressions and it meets this criteria, greater than 1 millimeter depression, again, from you have an isoelectric line here and the J point's at least greater than a millimeter below that, all right, or greater than 0.5 millimeters in V2 and V3, and you see horizontal downsloping type of configuration and it needs to be 2 contiguous leads, this is concerning for ischemia. Myocardial ischemia, such as unstable angina or STEMI. If I see T-wave inversions here, so you see how this T-wave, usually it's supposed to go whoop, and it's inverting here, that's definitely concerning for ischemia, right? And so if I see a combination of these two particular findings, I definitely want to start asking myself the question, what's the troponin level? If the troponin level is normal, that tells me it's unstable angina, right? Because there's no myocardial infarction. If the troponin's positive, it tells me that there is myocardial infarction. It's probably subendocardial, and this is an STEMI. And that's super important to be able to pick up, my friends. We call this non-ST segment elevation acute coronary syndrome, because acute coronary syndrome is consisting of STEMI, STEMI, and unstable angina. So if you see ST depression, T-wave inversions, and this ST depression is horizontal or downsloping, be concerned. Check the troponins and determine if it's unstable angina or STEMI. Now, not everything ST depression and T-wave inversion is always acute coronary syndrome. I think it's also, wise to consider alternative diagnoses like digoxin toxicity, so you could check a digoxin level, or hypokalemia, so you could check a potassium level. All right. With ST elevation, if I see ST elevation, what does that mean? That means when I look at the J point, it's usually greater. So if I have an isoelectric line here and I look at this portion right here, how much higher is it above this isoelectric line? If it's greater than 1 millimeter, right, and the limb leads, what does that mean? It means 2, 3 AVF, 1 AVL, AVR. If it's greater than 1 millimeter in any of those leads, and it has to be 2 contiguous ones, for example, 2 and 3, like lead 2 and 3, you would have to have ST elevation in both of those, not just one of them. Or greater than 2 millimeters in the precordial leads. What does that mean? It means you have to have greater than 2 millimeters, 2 of these actual two little boxes here, right? Has to be above the isoelectric line by 2 little boxes or 1 little box. If it's elevated above that actual isoelectric line, the J point or the ST segment, and it's in V1, V2, V3, V4, V5, V6, at least 2 of those contiguous leads. Can't just be 1. That's concerning, all right? That's very, very concerning for myocardial ischemia. But here's what I really want you to also consider here, which is the morphology of the ST segment elevation. Now, this isn't always perfect, but if it has a smiley face appearance, concave, that's less suggestive of myocardial ischemia. It could be more indicative of like benign early repolarization or pericarditis, maybe even hyperkalemia. Right? Here's another type of concave configuration, just another type of look of it. If you see convex though, that's not a smiley face, that's a frowny face. That's more indicative of infarction, myocardial infarction, and it's way more concerning of a configuration. Here's just another way, let's like that called the tombstone effect. This is very concerning for myocardial infarction. So not just elevation, contiguous leads, but also configuration helps me to identify if there is a concern of STEMI, right? That is really going to be present here. And then don't forget to check your troponins, because if I have an ST elevation, a troponin elevation, it may make me think about a STEMI. Now, hyperacute T waves, believe it or not, can actually sometimes be a finding of ischemia that can precede ST elevation. So sometimes patients will come in with hyperacute T waves that then start to bump into ST segment elevation. So just remember that. Maybe they don't come in with ST elevation, but they come in with this large, broad type of T wave here. This may precede them going into this tombstoning ST segment elevation. So this could be an early indicator of myocardial infarction that then will progress to this. All right. So either way, when I see ST elevation or hyperacute T waves, my first thought is a STEMI. So then I have to start thinking about where's the ST elevation, where's these hyperacute T waves. I got to localize the STEMI, right? So how do I do that? Well, the first thing it's important to do is remember your leads. So when I look at the ECG, I have to kind of have ST elevation and particular leads to determine what type of STEMI it is. For example, if it's an anterior STEMI, you have like anterior septal, so V1, V2, V3, V4. So if I see ST elevation here in V2, V3, and V4, and on top of that, you know what else suggests STEMIs? More than things like pericarditis, benign early repol, hyperkalemia, is reciprocal changes. And especially these reciprocal changes can occur in like 2-3 AVF. So if I have reciprocal changes plus ST elevation in like V2, V3, V4, this is super suggestive of an anterior MI. If I look here, 2, I see ST elevation, 3, ST elevation, AVF, ST elevation, and reciprocal changes in 1 in AVL. And look at the configuration of this thing. It's convex, right? This is an inferior MI. That's an inferior MI. The next one is lateral. That's usually 1 AVL, V5, V6. So ST elevation here in 1, ST elevation here in AVL, ST elevation in V5, and ST elevation in V6. And again, all it's got to be is it's just got to be in these particular 2 millimeters, and over here 1 millimeter. And if I have that in 2 contiguous leads, which I do in this one, look, I got a 1, I got an AVL, I got a V5, V6. This is a lateral, usually what we refer to as a high lateral STEMI. And you see reciprocal changes in 2, 3, and AVF. What does reciprocal changes means? That means that you'll see ST depression or like T wave inversions. The last one's a posterior STEMI. So oftentimes what I like to do is I like to look at V1, V2, and V3, and I look for T wave inversions and ST depression. So you would then say, oh, maybe this patient has like an in-STEMI. It's important to always have a high degree of suspicion for a posterior MI. So what you do is you take the leads and you put them on the posterior chest wall. And so you do something where you actually change it to V7, V8, V9. And you'll see here that they have ST elevation and V7 and V8, V9. So they have ST depression T wave inversions in V1, V2, V3. Slap on the posterior chest leads V7, V8, V9. It's ST elevation. That's a posterior STEMI. So you see now why it's super important to see, oh, ST elevation, it's there, all right, based upon the actual numbers of elevation above the isoelectric line. You see the ST segment, but then notice where it is. If there is that presence of the ST elevation, what's the morphology? It convex, concave. It can provide some, some justification if it's truly more concerning for ischemia. Then look at where it is. Is it in the anterior V1 to V4, and does it have reciprocal ST depressions and T wave inversions? That could be an anterior STEMI. Is it in 1 AVL, V5, V6, reciprocal changes seen? That could be some type of lateral STEMI. Is it in 2-3 AVF? Reciprocal changes are seen. That could be an inferior. And if you see ST depression T-wave inversions with V7, V9, they're posterior leads, ST elevations, it could be a posterior STEMI. In all of these scenarios, you should rule those out first. And once you've done that, then you consider things like pericarditis. Pericarditis oftentimes will also be associated with diffuse ST elevation. You'll see it in almost all the dang leads on the EKG, but then also have what's called PR segment depression. Also, the morphology is usually a concave morphology. And then hyperkalemia, I have seen this also cause ST segment elevation. Usually it'll come with those peak T waves or hyperacute T waves. Again, it's important for this one. It's really difficult to diagnose. Sometimes you have to just check a potassium for these patients. All right, my friends, that covers ECG interpretation. I hope it made sense. I hope that you guys enjoyed. I hope you now have a good approach and you're able to tackle any ECG that comes your way. All right, engineers, love you, thank you, and as always, until next time.